Hi, how are you? I'm Dr. Derek O'Keefe. What's your name?
James.
James, how are you? James, I'd like to examine your abdomen if that's okay.
Yeah.
Okay, that's good. So the first part of any GI exam is the correct positioning of the patient. For this, I'd like you to have you flat, so just relax there. I'll change the beds to be flat. Just lie flat now. You're not in any pain, are you?
No.
Good. So you've got to make sure the patient is horizontal. The next important part of a GI exam is to make sure the patient is adequately exposed, traditionally from nipples to knees. What's really important is that you properly expose the inguinal area. Okay. So with the patient resting on the bed, you do a general inspection. Okay, on general inspection, the patient themselves, they're not in any distress. They're not rigid in the bed, suggesting peritonitis. They're not writhing around, suggesting a kidney stone. They look well hydrated. They're not cachexic. There's no obvious signs of jaundice. And looking around the bed, there is no fortified drinks. There's no TPN. There's no nasogastric tube. There's no urinary catheter in place. And there's no surgical drains or tubes. From general inspection, we move on to more specific inspection. And with the GI exam, this starts with the hands. Are you in any pain, sir? Mm-hmm. Okay. Can you put your hands, please, on top of the pillow? So initially, we look at the nails for any changes associated with the GI system, such as leukonychia, colonychia, and Terry's nails. Can you turn your hands over, James? Thank you. Here we're looking for palmar erythema. And moving on to palpation now, looking at the palmar creases for pallor, suggesting anemia, and feeling the palmar suffers for any flexion contractions, such as Dupuytren's. Can you turn your hands over again, James? Now I'm feeling for fluctuance of the nail bed, for clubbing, and can you put your two index fingers together? And the diamond shape is present, showing no loss of the nail angle. Finally, James, can I ask you to put your hands out straight and cock back your wrists and hold them steady? You hold this for about 30 seconds, checking for any signs of liver flap. That's fine, James. Thank you.
Cool.
After inspecting the hands, to continue our GI exam, we remove the pillow and we examine the arms, looking for signs of pruritus and ecchymosis. Then looking at the face, we're observing for any signs of sclera icterus. I'm going to pull down your eyelids now, looking for any pallor of the conjunctiva, suggesting anemia. Then looking around the mouth for buccal pigmentation. Can you stick out your tongue, please? Looking for any candida, glossitis, or oral ulcers. And close your mouth. Looking for any angular stomatitis or jaundice. Then I would like to move on to examination of the neck. For this, I would like to assess your lymph nodes. So if you could sit up, please, and swing your legs over the side of the bed. Are you comfortable?
Yeah.
I'm going to examine you now from the back by touching my hands around your neck. So making sure the patient lifts their neck up and then drops it slightly so you can adequately feel the lymph nodes. You assess the submental, submandibular, the anterior cervical chain, assessing if there is a virtuose node present, the posterior cervical chain. Okay, you can lie down, James. Continuing my examination, I now inspect the precordium for any signs of spider nevi, any gynecomastia, or signs of hair loss. Continuing to the abdomen, can you put your hands by your side, please? I'm looking for any signs or incisions of previous surgery, looking for any tattoos, any abdominal masses or distension, any obvious hernia. Can you cough? No obvious hernias. And can I ask you to raise your legs together and down? And there's no divercation of the recti. Finally, kneeling down beside the patient, looking straight across the abdomen, looking for any visible pulsations such as a AAA. We now move on to the palpation of the abdomen. Ask the patient if they are in any pain, and if they are, to point to it with a single finger. Then start your palpation at the opposite side. Are you in any pain?
No.
So first we start off with superficial palpation, palpating the 9 quadrants, always looking at the patient for any signs of discomfort. This tests for any pain or rigidity. Continuing on then, we do deep palpation, looking for any masses, and again looking at the patient for any signs of pain or discomfort. After palpating the abdomen, we move on to assessing the liver size. Next, we're going to palpate the liver. For this, it's important to start down in the right iliac fossa, asking the patient to breathe in and out. Progressing the hand upwards, breathe in and out, and breathe in, breathe in. You're looking for the lower border of the liver, which may be just palpable below the costal border. Following palpation of the liver edge, we move on to palpating the spleen. Start in the right iliac fossa again. Take a deep breath in, and out, and in, and out. All the time progressing our hand across the abdomen diagonally. Usually the spleen is not palpable on clinical exam, unless in splenomegaly. However, you may appreciate the spleen if you ask the patient to roll towards you and take a deep breath in and out. Thank you, James. Now I'll move on to balloting the kidneys. Here you use your left hand to find the lateral edge of the rectus muscle. You use your right hand underneath the body in the renal angle between the costal angle and the spine, and you flick with the right hand. That's not sore.
Oh.
And again, on the opposite side, the left hand on top, the right hand in the renal angle, flick to ballot the kidney. Moving on now to special palpation exams for the GI system, such as the Rebound Test, pushing down the right iliac fossa and quickly releasing. If the patient jumps or shows distress at this, it is a sign of local peritonitis, typically of appendicitis in the right iliac fossa. Moving on then to Murphy's sign, finding the midclavicular line under the costal margin, pushing here and asking the patient to take a deep breath in. If the patient stops breathing in on inspiration, and the pain is not present on the opposite side for the same test, this is a positive Murphy sign showing cholecystitis. Moving on then to percussion of the abdomen. First we percuss for generalized tenderness, again looking at the patient for any signs of discomfort. The abdomen should be resonant from the bowel. If we do feel any dullness, we ask the patient to lean towards us. Wait a couple of seconds for any fluid to drain. If the bowel now becomes resonant, that means there is dullness and ascites present. You can lie back again. Finally, to check for a fluid thrill, we ask the patient to put their hand over their umbilicus, palm or edge. We put our left hand at one side of the abdomen, and on the other side, we do a strong flick and we feel for any fluid thrill. The final part of the GI examination is auscultation. Here we are listening specifically for bowel sounds with the diaphragm stethoscope. We also assess for any renal bruit. Or any turbulent flow of a AAA. I'd now like to assess the patient for the presence of an abdominal aortic aneurysm. For this exam, it is important to realize the anatomy of the abdominal aorta. It lies on the left-hand side medially, and it bifurcates superiorly to the umbilicus. So when assessing for a pulsating aortic abdominal aneurysm, use 2 fingers on either side of where you expect it to be anatomically. Gently feel for any pulsations. Up and out is the pulsation you expect to feel. Moving your fingers laterally to where you feel a pulsation. And then once you assess it, moving it slightly back in again to confirm. This then is the width of the abdominal aneurysm and should be noted. To conclude the GI exam, you proceed to examine the external genitalia, perform a digital rectal examination, do a urine dipstick, and assess the shins for any signs of erythema nodosum. This concludes the GI exam. Thank you very much, James.